Ghosh. Dr. Shujita is a consultant radiologist at the Apollo Multi-Speciality Hospitals in Kolkata. She is also one of our DNB examiners. And she is a musculoskeletal expert and she's a passionate teacher. And that is something which you will understand when you attend this session, that it is, it's good to hear from a teacher who is able to tell you what is the important thing and what has to be stressed upon. So again, a very warm welcome, Dr. Shuchita, to help us out at the time of the exams. And it's over to you now for conducting this session, as you please.
Thank you so much for the warm introduction. It's always an honor and a pleasure to be on the forum. So without delay, I'll start. Now, just an introduction as to what an OSCE is. It's a structured way of examination there. Not only an interesting case, say either one modality or multiple modalities are kept in front of you, but there are few questions associated with that. So unlike a spotter where you just have to give the diagnosis, here you have to know some associated questions. And if you can answer them completely, you get a solid full marks, 4 marks or 5 marks, whatever. So not only do you have to know the diagnosis, but certain important findings, and it comes out of practice. OSCEs need a lot of practice, unlike spotters, so that you can get full marks in that. So let's go, let's start. For every OSCE, there'll be a image, a few questions. I'll be giving you a certain time limit and you have to write in the chat box. After the time limit is over, I'll see whether your chat box answers, they are correct or not. If they aren't, I'll show you the correct answers. That's about it. Not much of teaching in this because everything is there in the books. Want to just test whether in these 4 minutes you can get the correct answer perfectly to all the subparts or not. Let's answer. If you've noted down the questions, I'll just go back to the what is the complete diagnosis? Why can't you see the images? I have come back to the images. Archana, are you able to see it now? Are you able to see the images? So what is your complete diagnosis? Now I won't go back to the images. Answer the questions. Let's go to the answers. People have answered sesamoiditis of the right great toe, hallux sesamoiditis, sesamoid fracture, bipartite sesamoid bone. So enough time. What are the answers? So see, I had told you to give a complete diagnosis. There are two sesamoid bones, out of which the medial one is bipartite and the other one, if you see, has become sclerotic and irregular. So what has happened? Likely there's osteonecrosis with sclerosis of the lateral sesamoid. People have answered this correctly. What is a bone formed within the tendon? Yes, but nobody answered what is the largest sesamoid. Sorry. What is the largest sesamoid? Nobody's answered. So this you should know. Patella is the largest sesamoid bone. And any two other modalities. One is already seen here, CT scan, because it's a bony structure, CT scan. And sometimes bone scintigraphy can help you by seeing a hot spot for the inflammatory area, or complete necrosis, there won't be any changes. So see, all of you could partially answer the subpart 1 and the second. So even if you know it, you will not get much marks because you haven't completed the whole thing. So you have to be very fast. Let's go to the second. Swelling of foot, particular digit, no pain, no signs of inflammation. First see it, formulate what it is, then I'll come to the questions. Don't write before the questions come up. Remember, it's an OSCE. Whenever you see multiple images in MRI, first try to see what are the sequences and how the pathology looks in each of the sequences. I won't be telling you. You should be understanding what sequence is this, what sequence is this, corresponding radiograph, indolent swelling, long term, no signs of inflammation. Patient has minimal rise in temperature at night and moderate weight loss. Again, someone's giving out of turn answers. I have not yet come to the questions. OSCEs, you can't answer like that. I may not be asking you what it is at all. Please follow the questions. So what is the diagnosis? Write them, then I'll come to each of them. I'm in the middle of my session. Coming to the answers, most of you have got it right. It is a case of tuberculous dactylitis. What is the likely etiology? People have got it right. What are the possible closest differentials? Someone has right. Where else can we find similar lesion? By that I meant, where do I get dactylitis like this, right? Someone's written hand. What is the closest mimicker? Anybody can write it fast. What is the closest mimicker when it is found at another site? Hand, that is the hand. What is the closest mimicker? Sarcoidosis. What else? What else? Sarcoidosis produces, spina ventosa is the name of the thing. Enchondroma. Okay. Why sarcoidosis produces lacy pattern? Look at the extension, the expansile lytic lesion. So dactylitis tuberculosis, one of the any answers is chondrosarcoma metastasis, right? Enchondroma, phalanx of the hand is that answer, and enchondroma. So most of the people got this more or less right. Okay. So let's go to the next. Chronic discharging sinus, very horrible condition of the foot. This can be given as a spotter. This can be as a major quiz. Don't write the answers till I ask you to. Please follow the questions. See this for 20 seconds before I start. Are my images visible? This is quite straightforward, nothing more to see. I'll go to my questions. One by one, write all the questions, all the answers. What is the diagnosis? Chief complaints, I told you only. There are 3 questions only. There's a mistake in the alignment. What is the diagnosis? What is the chief complaints? What is the differential diagnosis? Wow. All, all correct answers. Since people have got it, I'll go. Yes, it is Madura foot, mycetoma, discharging watery fluid, pus containing grains. And yes, two differentials. People have come up with both Charcot's foot, neuropathic joint. Very good. So most of the people have got it right. Excellent. Question number 4. Pediatric patient has come with a limping gait, cannot weight bear. Don't write the answers till I show you what I want. If you can't understand exactly, there's a lytic lesion over here, femoral neck, along with something else, which is clearly seen in the other modalities. There is no history of major trauma, but okay, very brittle, I mean, very subtle injury, but patient has landed with this. For a complete rest of the MR scans. Complete diagnosis. Start answering. Anushwa, correct. Fibrous dysplasia with pathological fracture, ground glass, and name 2 syndromes. Come on. One already you've written. Another one. Another one. I'm asking about 2 syndromes. Very good. Done. Done. Manisha. Manisha. Karan Lalwani. All got it. Perfect. Fibrous dysplasia with pathological fracture. Yes. Ground glass density, McEwen-Albright syndrome, and Weissenberg. Excellent. So full marks on this, Oski. Okay. You are having a resident night duty and you're asked to come and see this MRI of a road traffic accident case, who's not even letting you touch the leg or hand, whatever. This is elbow, sorry. And you're seeing this. Try to recognize the sequences and try to see the location of the pathology correlate with the history that I gave. Again, someone is writing before I am asking you, showing you the questions. Don't do that, no. Then the people get to know the answers. Start answering. Anushwa, correct. Fibrous dysplasia with pathological fracture, ground glass, and name two syndromes. Come on. One already you've written. Another one. Another one. I'm asking about two syndromes. Very good. Done. Done. Manisha. Manisha. Karan Lalwani. All got it. Perfect. Fibrous dysplasia with pathological fracture. Yes. Ground glass density, McEwen-Albright syndrome, and Weissenberg. Excellent. So full marks on this, Oski. Okay. You are having a resident night duty and you're asked to come and see this MRI of a road traffic accident case who's not even letting you touch the leg or hand, whatever. This is elbow, sorry. And you're seeing this. Try to recognize the sequences and try to see the location of the pathology correlate with the history that I gave. Again, someone is writing before I am asking you, showing you the questions. Don't do that, no. Then the people get to know the answers. Now coming to the questions. Now answer. This is not a spotter session. This is a OSCE session. Now answer one by one. Ronak Savani, you're right about your answer. Now I want the answer to the other parts. Yes, it is a degloving injury. What is the likely history? Shearing injury, right? Okay. Number 3, thigh. What is the most common site? Thigh. Closest differential. Very good. Hematoma, abscess. That's it. So it's a degloving injury or a Moral-Lavalley lesion, and the shearing stress. This word is important. That's what is high energy shearing stress causes this. Thigh is the most important area where a common area, and hematoma and abscess. Right. Good. Now is a easier pattern because you have the questions right beside your. Don't start writing. Just read it for a while and then only start. You can start writing if you wish. Geographic lytic lesions in skull and LCH, Rushoti has written, or Langer says, please don't use short terms. You'll get enough of time. Please don't use short terms. Now let me see who can write this. Everyone has got the first one for second. What are the differences between adult and pediatric lung manifestations of this disease? Take your time. Do you know about it? Anybody knows about it? Write it. Okay. Where? In whom? Cysts of varying sizes, upper lobe predominance, in whom? I'll come to the answer. Read this. So geographic lytic lesions with multiple lytic lesions, beveled edges, LCH. So uniform lung involvement without zonal predilection in pediatric patients, whereas in adult pediatric, there is upper lobar predilection, and in pediatric lung, it's always accompanied by multi-system involvement, whereas in adults, it can be an isolated lung involvement. So this is the importance. Okay. Okay. If anybody has, give the question mark, question number and answer. Complete. What are the imaging findings? Dr. Jasveer has written bilateral avian. What is your finding? Snow cap sign. Name two differentials. Name two differential diagnosis. Name two conditions where you will be having this. Sickle cell and steroid. Baba, who's written all this? I read to everyone. Very good. Very good. So the answers are yes, sclerosis. So you just write yes. This is avian, but what is the stage in? We are seeing a collapse, contour deformity of bilateral humeral head and irregularity. Femoral head in this case was not totally collapsed, but there was irregularity, sclerosis. Wherever there is bilateral avian, you have to suspect some hemoglobinopathy like sickle cell disease, systemic hemoglobinopathy, and or steroid induced avascular necrosis. And yes, something which can help you, a history will help you, of course, of long-term steroids and hemoglobin electrophoresis. Blood investigation of not only blood investigation, you have to write, I read that it is the hemoglobin electrophoresis. Okay, got it? So that's nice. Okay. 40-year-old patient with long-standing backache presents with sudden onset, increased severity. See then, and I can show you the questions. Don't start writing. OSCEs, you can, whatever, whoever are exam going students, form a group, make OSCEs and ask each other. That's how your OSCE dictionary, OSCE library rather, will expand and you find a lot of common things coming in the exam. And once you start making OSCEs, automatically you'll read the theory part. So what are the questions? Give 1, 2, 3, 4 like that. What are the main findings? On MRI? Complete. What is the name of the complication that you're seeing in the image? What is the name of the complication? Okay, sclerotic fracture. Then my voice is breaking. Is my voice breaking?
No,
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 ma'am.
Sujata, it's
No,
not
ma'am.
breaking. It's fine.
Okay. So someone's writing that. That's
I
fine.
think they need to check their this.
Acha. Okay. So when you are writing findings, a little detail that we are seeing fatty changes at the anterior corner influence multiple vertebrae, suggestive of Romanos lesions. There is squaring of vertebra, anterior syndesmophyte formation, and the lesion is called a characteristic fracture. So just don't write ankylosing spondylitis. When I'm asking you what are your MR findings, that is different from what is the diagnosis. Remember this. So when the findings, you have to give a little detail because that itself is going to carry 2 marks. So if you don't write, you will not get 2 marks. Status of SI joint, fused or chronic, whatever. and other characteristic structure, everything is else. Did anyone write about the HLA-B27? Everybody will write, know that. Again, someone is writing. Anyway, maybe you're, for the time being, you're using short form. Please don't use short forms when you're giving the exam. Write HLA-B27 total. Okay, so that's about it. Okay. 22-year-old lady with sudden onset severe pain in the forearm. Since this was a superficial lesion, the patient was taken to the ultrasound. This is what it revealed, the specific finding. Start writing the questions. If someone wants to see this back, let's see how you nicely describe this MRI. I have 2 marks is given. What are the MRI findings? Someone write it. The question number is first write this and diagnosis. Rest all is okay. I want to see how someone describes this thing. That's why I've taken it back to the everyone is just giving the diagnosis. What are the MRI findings, please? This Rusuti and Jasveer always hurrying to give the diagnosis. Please give the MRI findings. Description is what is important. Can anybody describe? Again, rushing. So what is it? There's a well-defined cystic lesion with an intralesional nodule. That's why you're coming. So this well-defined cystic which appears, so the cystic characteristic is very nicely seen in the ultrasound, and there is diffuse muscle edema that shows that there is something which is causing a localized inflammation to the surrounding muscle, and this nodule is what is giving us an idea that this is likely a myocystic Everybody knows. None of you have written the findings in the forearm MRI. Then that part 2 marks 0. Even if you write the diagnosis, if you don't write that, this is OSCE, this is not spotter. So you have to be perfect in each of your subparts. This to everybody. So if you don't give this properly and you're writing about all this, you will not get the full marks. So don't rush. Remember, this is OSCE. So some muscle edema. So IRAD has written nicely, showing muscle edema, cystic lesion, showing muscle edema, cystic eccentric nodule. Very good. Very good. This should be the perfect, whoever is this, IRAD has written it beautifully. I'm very happy with this answer. Okay, rest of it is okay. Differential anything, intramuscular abscess, hematoma, and antiparasitic agents. Even if you write, that is okay. Don't have to specify the names. So this description by IRAD is what you have to follow. All of you are jumping to diagnosis, writing only the diagnosis. Don't do that. Long-standing pain, young patient. Complete diagnosis, I'll ask you. Wait, you see the questions? What is the diagnosis? What is the most likely important symptom? I'm going back to the image. What is the diagnosis? People who are used to MRI reporting in your hospital, knee joint is something which is the most common MRMSK. Start writing. What is your diagnosis? Remember, when you are writing about any MSK and if there is any side mentioned, please mention the side. It is written above. Someone has written the answer. Kashyapuri Ramesh Kumar. See, that's why I've given this. It is written medial below and lateral below. And you're finding you are still writing as discoid lateral meniscus. You will get 0. It is a discoid medial meniscus. Just by this appearance, because lateral meniscus is more common, you're jumping. You haven't seen that this area, this is medial written here. So it's a discoid medial meniscus, which is relatively uncommon. That's why I've given this as a spotter. What is the common presenting? Clicking sound, pain. What is the most common site? That is lateral meniscus is a common site. Now someone answer this question. Which of the following is true? Pick up the correct answer and just write it down in the chat box. I'm giving you 10 seconds. Someone's written it A. So if so if it is ABCD, you just write it. The condition is congenital and frequently bilateral is the answer. Okay. So what is the teaching point here? Medial, lateral, please see before you write. Otherwise, your question is you know the answer, but it will go wrong. This is about MSK. Wherever there is right left tissues, see that. Okay. Okay. Patient has come with stiffness of the shoulder and difficulty in abduction. Don't start writing. Don't start writing till I tell you to. Just observe. Just for people to see what is the question I would be asking, go to the question, what is the diagnosis? What is the stage of the lesion? Okay. Now I'm coming back to this. What is the diagnosis? What is the stage of the lesion? Patient had come to the radiology department with acute pain shoulder with likely rotator cuff injury. To rule out rotator cuff injury. What did we find? Start writing. What is your diagnosis? This I'm asking you, what is the diagnosis? And what is the stage of the lesion? Intraosseous lipoma of humeral head, very good. Anishwa and Karan Lalwani are doing really well. Who has written this? OCD? No, it's not a OCD. Fat necrosis of lipoma, very good. So it is stage, simple cyst with fatty involution. Stage, what is the stage? Correct, it is intraosseous lipoma. Do any of you know the stages? What stage? Try someone, right? Stage. Okay, I'll come to the stage. Which is the bone mostly commonly affected? Which is the bone most commonly affected? Calcaneum, calcaneus to calcaneum. Yeah, Charlie, correct answer. What signs suggest presence of central calcification? Very good. IRAD. I think IRAD is going to sit for this coming exam. Knows everything. Very good. So, intraosseous lipoma, it is a stage 3. So stage 1 is total fatty. A little bit of necrosis starts is stage 2, but more of fat. When it becomes really necrotic center, it is stage 3. Answer calcaneum, Crockett site. Very, very good. I'm very happy with some of them. I think they're going to answer everything in the coming DNB actual practicals. Okay. 18-year-old male, pain, rigidity of the foot, no history of trauma. Again, don't jump. I will ask you the questions. Questions. What is the diagnosis? Wait. What is the diagnosis? What is the type? So talocalcaneal coalition. What is the talocalcaneal? What is the diagnosis? Tarsal coalition. What is the type? Talocalcaneal. What is the other type? What is the other type of coalition that you know? Tarsal coalition, tallow. What is the other common navicular? Calcaneo-navicular. Why only navicular, Anaswa? Calcaneo-navicular. Good. Name two associated signs. Let's see. C sign, anteater sign. Very good. Reverse anteater is also there. So, talocalcaneal coalition, tarsal coalition, talocalcaneal, other is calcaneoclavicular, two associate C sign, anteater, nose sign, very good. And another common question that can come with coalition is what are the types of coalition? Osseous or fibrous or cartilaginous, and you have to know the names. What is synostosis, synchondrosis, syndesmosis? This is not there in this OSCE, but it's commonly asked as a part of the OSCE question. So when you're reading about consolidation types of signs, coalition is a very common DNB spotter. So these are the possible questions that will come. Okay, so that's good. Now this will be our last rapid fire round. Start. What is this entity called? Write quickly. I'll give 3 seconds, but very easy now. What is this entity? Name two conditions where it is found. No, don't. I have pointed out, I have given a marker to show you what is the entity that I'm asking. What is that? What is that entity? People are, that's what. Please think, command triangle. Who is Rushoti? Ask, read a command triangle. It's a Codman's triangle. Name two conditions where this can be found. Name two conditions. Let's see. Elevated periosteum. No, elevated periosteum will not do. It has a name. It's a Codman's triangle. Name two conditions. Ewing's sarcoma, osteosarcoma. Very good. Name one non-malignant condition. Write it someone. Non-malignant condition. Very good. Osteomyelitis. Raviraj, you're right. Name one more radiological modality which can clearly depict this. Why MRI? When I'm talking about periosteal elevation, why should MRI be the first choice? It should be CT, no? So Codman's triangle, not command triangle, Codman's triangle, osteosarco-Ewing's, acute ulnar, CT scan. Good. So don't hurry and write wrong things. Spotter, but I will ask it in the form of a OSCE. Since these are absolutely, you will see and you'll be able to understand what you're dealing with. So start answering the questions. Let's see. Oh, where did I go? Got it. Yeah. Let's see what people are doing. Bone tumors, before you commit something, please see location and age, tentative age. Chondroblastoma, age group. Immature skeleton. Commonest bone, commonest location. Oh, commonest location is around the knee joint, femur. Name one diagnostic MRI finding. Let's see who writes this answer. One diagnostic MRI. You are right about your diagnosis. What is the diagnostic MRI finding in this entity? What is the diagnostic? I'm saying in MRI. Why are you using the word sclerotic? I mean, what will the signal? T2 bright, T2 hypo. See, Parul is writing wrong. So extensive edema, peripheral rim of low signal intensity is characteristic of this. Okay. So please be careful about what you're writing. Correct. Very easy. Everybody knows this. I'm going to go to the questions. What is the entity? Everybody knows. Write fast. I'll give you 2 seconds. 2 seconds. Name one characteristic clinical complaint. Right fast. Clinical complaint. Night pain. Very good. Name one symptom relieving medicine. Symptom relieving medicine. NSAIDs. Aspirin. One role of interventional radiological for management. RA2. Good. Great. See, these are easy things and you will finish it in 15 seconds. So if this OSCE is given, you will write nicely, be satisfied and switch throughout the rest of the 5 minutes. Say, what a beautiful thing I've done, complete. Good. But they might not give such clear cut osteosarcoma. They can give it in any location, in any modality. So this is one entity you have to know in and out, all about. Okay. Okay. Pain, hip joint. Let's see who gets this. Again, very easy. Are Bob. Raviraj has got it. Okay. Name 2 conditions, Raviraj, fast. Name 2 conditions. Name 2 sites. People are putting in all the, everybody is very good at radiograph, plain radiograph. Finally, what is Honda's sign? Someone write it. Honda's sign, yes. Not only sacral insufficiency fracture, but bilateral sacral insufficiency fracture. So yes, it's a Looser's zone. It's an insufficiency fracture. We are seeing this over here. See, this is the common location perpendicular to the line of the cortex. 2 conditions, there are multiple. So any of these you write, you will get it correct. And what are the common sites? Any you write will be correct. Everybody has written multiple. And bilateral sacral insufficiency fracture, radioisotopes cracks is for Honda. Easy, 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 easy. Number 5. What is the entity? Very good. Name one syndrome associated. Name one syndrome. Already the similar question has been discussed with. Syndrome, syndrome, syndrome. Okay, Macular again. So we had seen an MR of this thing, and this is a shepherd's deformity. So easy. Okay, this is very easy, very easy. What is this entity called? Again, IRAD is in a hurry. HPT. Characteristic location. Characteristic location. Characteristic location. Again, white hand. Baba, that is something specific. Who is writing psoriasis? Yes, radial aspect of phalanx. Very good. Second and third digit. Lab finding. Come on, come on. Important lab finding. One important lab finding. ANP. What about the serum calcium and parathormone level? Anything can important do when you're talking about what would be the vitamin D level in this patient? What would be the vitamin D level in this patient? Normal, if it's a case of primary hyperparathyroidism. Okay, so these are the possible things which can come. Low calcium, raised parathormone, vitamin D normal. Similarly, on the other hand, if you get a picture like this and you are asked questions, what is the everything? Everybody knows what is this called? Come on, write someone, right? What is this called? What is very good, very good. Name the condition where is it found? Full condition. What is the condition where it is found? CKD with secondary. Very good. In one mention the pathogenesis of this. What is the pathogenesis in one line? One line. Can anybody say? Why do CKD patients have this? And name 2 causes of diffuse bone sclerosis. I'll go to the answer. So it's Ragajasi spine in renal osteodystrophy. Hyperparathyroidism is secondary to the hypophosphatemia combined with calcemia, both of which are due to decreased excretion of phosphate by damaged kidney. And you have to know DD is absolutely in the tips of your hands for diffuse bone sclerosis, spotters actually. What is this entity? Name two conditions where this is found. Name one condition where you find this with no history of trauma. Come on, answer. Number 1, 2, 3, like that. What is this entity? Name two conditions where this is found. Name one condition where you find this with no history of trauma. Let's see what are the answers people are giving. Humoral calcinosis. So it is a soft tissue. What is that? There is soft tissue calcification. So this can be found in secondary hyperparathyroidism, humoral calcinosis, myositis of calcification. And so if one condition where you find it without history of trauma, it is secondary hyperparathyroidism. Okay, myositis ossificans usually the history of trauma. Last two left. This is how will you describe this? Can anybody describe this fast? Describe the condition with two differential. Why are you talking of ABC directly when I'm not? You don't even know what this is an adult or unfused epiphysis. Why sarcoidosis? Expansile lytic lesion. So any description with narrow zone of transition. So you have to know that the basic things. Expansile lytic diaphyseal lesion with two differential. This is not a cortical based lesion. With two differential diagnosis. If I say brown tumor. Now, if corrected calcium is very high in this patient, correct, what would you think of? And what would be one important radiological test? Let's see. One important radiological test you will perform. One important radiological to confirm the diagnosis. What would you take the patient? Where would you take the patient from the radio X-ray room? Very good. Who has told me this? From Swati. Very good. Very good. So, see, you're clinically correlating with the finding. It's a case of any, if you know that benign lytic lesion, it's a bone tumor or simple bone cyst, primary hyperparathyroidism. Unless you're sure about the age of the patient, don't comment on BCT and ABC tests like that. Last. Name the condition. What is this condition? What is this condition? Name the condition. Very good. Salt and pepper skull. What is the radiology? What is it due to? I will not go to the answer. No. What is, why does this mottled appearance of the skull? What happens resulting in this? Hyperparathyroidism, fine. What happens in what resorption? What resorption results in this? What? There are several kinds of resorption. What hemorrhage? No. What is this just be writing hemorrhage? What results in this pattern? What resorption? Anybody listen? What resorption? No, it's not trabecular bone resorption. Trabecular bone resorption results in mottled appearance. That is very important. Name two characteristic lab findings. Someone? Characteristic lab finding. Okay. No calcium here. And again, another important radiograph that we need to confirm the diagnosis is the USG then. So, what's the time? It's almost time. That's about it. Thank you very much.
Thank you, Dr. Shuchita, for this excellent class.
But everybody is answering everything. All 100 out of 100 in OSCEs.
That will remain to be seen.
Yeah.
But I'm glad that they have an idea of how it has to be answered, and yeah, it's good. Let's see.
So this is all about OSCEs. What you got learned is don't hurry with the answer. Wait for the questions, answer to the point, and have a little clinical knowledge about everything. And that has to be done only by discussing with friends. Join a group and ask each other OSCEs. Okay. Hope everybody liked this session.
Yes.
People are telling me it's
There are a
good.
lot of heart
Many
signs,
people,
heart
hearts.
emojis.
Yes, yes. I'm so happy with so many hearts. And Anup has given me a fire. Okay. Thank you very much. I really enjoyed this session. Thank
So
you, National Board.
the thing is that in the exam, I just want to point out to the students that we try and give the images and the question on one page only, right? So when you see the OSCE, you will see the OSCE, supposing it's in two parts, then it will be 2A, 2B. Otherwise, we try to put the relevant images there and the questions there. So now I'm just trying to tell you that be careful, as Dr. Srijata has also pointed out multiple times during this lecture, that please do not hurry up and answer the questions what are asked. Supposing they're writing finding and you write hyperparathyroidism, and the second question is what is the diagnosis, and again the answer is hyperparathyroidism. So where do we give you the marks? Because every question comes with a set of answers or keys where it has to match with that. So you may be right that it is hyperparathyroidism, but when the question is tell us the finding, then you have to tell us the finding, right? So that is very, very important. And for all of you who are asking for more classes, actually the classes have been held. There have been, all the OSCEs have been discussed multiple times during the course of last year. And spotter sessions have been taken and cases have been taken. So, but, and of course we have to compliment the teachers also. Dr. Shuchita, of course, is, as you all already have seen the last time, she's a passionate born teacher. And what will be the exam pattern? Exam pattern will be exactly as it was last year. So there will be an OSCE session, there'll be cases, and there'll be Viva. So for all of you who are preparing for it, I'll meet you again for some time. For DMRD, there are spotters instead of OSCEs. There is no OSCE for diploma. There is only OSCE for the NB board exam, but not for the diploma candidates. So all the very best to all of you who are going to give the exam this time. And we'll try and have maybe one more session, maybe of physics before the exam. I'm not sure at the moment. So thank you, Dr. Shuchita, for your help. And
Thank you,
you are
Dr. Anjali.
excellent
Thank you, National Board. And all the
collection of
students are so good.
arterial, peripheral arterial Doppler next week. So this is also important because it can be asked in the exam, it can be a question, and it can be asked in the practical exam as well. So thank you very much.
Okay, bye. Thank you.